guys, we are so glad that you're here today, and we are talking about probably one of the most, or maybe the most important organ in our body today, and that's our heart, and how to keep it healthy. Because guys, when we roll out of bed every morning, guess what? That thing's got to be going, right? It's got to be working, and when it doesn't work, or when it doesn't work right, we either don't feel good or we're not here. So, Dr. Schultz, who's been in our community for a while now, he was here last year during Heart Month, is going to come and remind us. I don't know about you guys, but I have to be reminded what I need to do. And I don't know if that's age, or maybe I should say the season I'm in where I have to be reminded, or if I'm just that strong-willed. But I have to be reminded of what's good for me and what's good for my heart. And so he's going to do that today, and I want us to all do something a little different today. I want us to think about ourselves. I don't usually promote that, but I want us to think about ourselves as Dr. Schultz comes, and I want us to ask ourselves the questions that he will bring to us today. Are we heart healthy? And if we're not, what are we going to do in 2019 to get there? And then more importantly, what can we, Coosa Valley Medical Center, or Dr. Schultz and his group, do to help that be reality for you? So with that, I'm going to ask Dr. Schultz to come and get us started, get us fired up, get our heart beating, pumping, not skipping, but beating and pumping. And when we leave here today, I hope we feel challenged to have a healthier 2019. So Dr. Schultz, it's all you.
For those of you that don't know me, my name is Dave Schultz, and I'm with ACG. I live in Birmingham, but I get the pleasure of coming down here every Monday. I consider it my favorite day of the week, so I appreciate y'all having me. So, you know, we sometimes get up here and we talk about a lot of fancy stuff and fancy technology, and oh, we've got this great new stent, and oh, you're not going to have surgery anymore, and you know, all this technology that we have these days in medicine and our heart. You know, and I sat down and I thought, you know, maybe it's just smarter to talk about some of the basics today. The basics particularly being coronary artery disease. And I'm going to define that a little bit better as we go forward. I want to talk a little bit about, you know, the things that you can do to avoid it. So I'd always much rather do a heart cath on you and tell you that your arteries were normal than to tell you about this great new stent I just put in there. Better to not need it in the first place. But certainly I also would like to speak to, you know, I'm sure there's people in the room or you have friends that have coronary artery disease already. And what can we do to manage that? You know, coronary artery disease 50 years ago, people just didn't survive it. And now it's kind of turned into a chronic disease that we just kind of manage. And so we've done a lot of good things, but I really want to kind of, I don't know that you're going to learn anything new today, but I think this is important information for us to be reminded about. So coronary artery disease, what's that mean? So, you know, we always hear a lot of stuff. So you may hear somebody say, oh, I got a blockage. Or you may hear the more scientific word, atherosclerosis. Or you may even just hear the word heart disease. Doctor, do I have heart disease? Or somebody may not even say any of those things. Well, my doctor told me I need a stent or I need a bypass surgery. And I will say that this whole definition of heart disease, when we say heart disease in this country, you know, really heart disease means any heart problem. Blocked up arteries, heart failure, rhythm problems, valve problems. But when people hear the word heart disease, the thing they really think about is this issue of coronary artery disease. So our heart needs fuel to do its work. So all that blood that gets pumped through your heart every day is not feeding your heart. Your heart's like a water pump. It just takes the water in and passes it on. So just like any pump needs energy, gasoline plugged into the wall, our heart needs energy to do its work. So the energy that our heart runs on is oxygen. And oxygen is delivered by the blood, and the only way that blood gets places in your body is through a blood vessel. So in your heart, the arteries that feed your heart are called coronary arteries. They live on the outside of the heart. The blood travels through there, goes down to the capillaries, and drops off the oxygen, and that's what feeds our heart, allows our heart to do its work. Well, unfortunately, and particularly in this country, whether that's from people are living longer or because of our diet or because of genetics and for various reasons, sometimes those arteries can become diseased or blocked. And so that's when people say, well, I got a heart blockage, they mean coronary artery disease. Atherosclerosis, that $10 word up there, really is the kind of scientific word for hardening of your arteries or causing plaques to form in your arteries. So atherosclerosis can occur anywhere, your heart arteries, your leg arteries, your carotid arteries. So that's that process by which plaques form. So this is just a little cartoon of an artery. And so you can see here on the top, this is a normal looking artery. And if you look at it, if you cut it in half and looked at it in cross section, that middle area is kind of the hollow area. The red part is the muscular part of the artery, and you can see the tube is wide open. In coronary artery disease, we start to develop this plaque. You can see that there in that yellow. And that's not just cholesterol, it's kind of a combination of cholesterol and inflammatory cells, and even smooth muscle cells that were part of the artery in the first place. So if you look at a plaque underneath the microscope, you'll see some cells that look like cholesterol, and you'll see some cells that actually look like part of the artery. So this plaque doesn't necessarily just form as a layer on the artery. It kind of intermixes with parts of the artery, and they're tied together. So people have always asked me, well, why can't you just peel that thing off and be left with the good artery? Because really, they're all tied together. My idea that was going to make me my first $1 million was if we could just come up with intravascular Drano and put some Drano down there and melt that thing off and be left with a nice normal artery, everything would be fixed. But the problem is we don't know how to dissolve the bad and keep the good. So as of this point right now, we don't have that. But you can see as the plaque forms, this area where the blood can get by gets smaller and smaller and smaller. Until at some point there's hardly any room there, and that's when we have problems. So, sorry it's right after lunch, but this is a real live version of an artery and not a cartoon. So this is an aorta from somebody that had atherosclerosis. So you see these areas here that are kind of red, a little there, a little there. That's actually the normal part of that blood vessel. And that yellow is the plaque. So as you can see, this is a severe case of atherosclerosis where almost the entire vessel is covered in plaque. So we don't want to get here. We want to stop this before we get to here. So what happens? What are the stages of this? So this is a nice healthy artery right here. You see the little red blood cells going through. Slowly, at some point, we start to build up. Some people even think that we start making plaques and fatty streaks even when we're kids. And there's really a push these days in the pediatric literature is that we should be checking cholesterol in younger and younger people because these things always start as these fatty streaks, and we don't know when they start, right? Because we don't have a way to go look in there, but they're there. And so finally you get to this point where a plaque forms and you start to see the squeeze right there. Not enough room for the blood to get by. Now in this case, at rest, because your heart's not having to work very hard, you can get enough blood to come across there and you don't really have a problem. But once you start walking up that hill in the backyard, or trying to bring the garbage can in from down by the road, or go up a couple flights of stairs that seem to be getting higher and higher every couple of years, at some point you can't get enough blood across that blockage, so you're not delivering enough oxygen to the heart, and you start to have symptoms, and we're going to talk about that. Now, the thing we're trying to avoid, this does not have to become this. It can become this, but the two are not, this is not necessarily a progression, that if you have this, that it's going to become this. But this is the feared complication of a plaque. So a plaque, for some reason, and way out of the what I need to talk about today, but really we don't really understand why. Sometimes plaques become unstable, and that plaque will crack, or pieces of it will break off. And your body will say, hey, wait, there's some damage inside my artery. And so the body does what it does when it sees damage, just the same as if you cut your arm. It says, I got to wall off that damage. So what happens are these little cells called platelets start to stick to that ruptured plaque. And then they become activated. And then they turn on the blood clotting system. And all of a sudden you start forming a blood clot in your artery. And now, as you can see, there's no flow in the artery. And this is what happens in a heart attack. Okay? We don't like this, but we can deal with it. We hate this, and they don't have to, this doesn't have to happen just because you have that, okay? So, I think I want to I'm going to dispel some myths today. So, the fact that you get a stent does not mean you had a heart attack. You can have a heart attack and need a stent, but just because you had a stent doesn't mean you had a heart attack. A heart attack means that you didn't get enough blood to your heart. And so there was damage to the wall of your heart. So that means, by definition, a heart attack means you had some damage. Now, there's a lot of people who have coronary artery disease, and they'll just come into the office and say, Doc, I think I'm just getting older. I can't walk like I used to. And I have to tell you, when I come up from a workshop in the basement, I get this little funny heaviness here in my chest. Now I go sit down in the living room and it feels better. But every time that happens, it happens. And you know, I'm kind of having a hard time running down to the mailbox and getting back up the hill to the house, because it feels a little funny in there. And so when you have coronary artery disease, this is not a heart attack. A lot of times you'll start having some symptoms that can give you at least a clue, hey, that maybe something's cooking. So what's the most common reason or symptoms you can have? So exertional chest pain, meaning, hey, at rest, I'm fine, but anytime I try and do anything physical, I get this chest pain. Now, lots of people don't like to say chest pain. Doc, it's not pain. Let me tell you, it's not pain. It's heaviness. It's an uncomfortable feeling. I can feel something going on right here, but I don't want to call it chest pain. So any and all of those things count as chest pain. Yeah, it's every time I go up the stairs, it's uncomfortable there, so that's chest pain, okay? Frequently, you'll have associated shortness of breath, particularly when you're trying to exert yourself again. You know, everything seems good when I'm not doing anything, but when I push, this is a very frequent, and we see this frequently in diabetics. Diabetics, many times, will not have chest pain. So diabetes, which is not just a sugar disease, it's a blood vessel disease, it's a nerve disease, makes it so that you don't feel chest pain in the normal way. So it's not infrequent for diabetics to come in and just say, yeah, this don't feel so good. I don't know. You know, I just not doing as good as I did. And so what we'll notice is a loss of exercise capacity. And I'll ask my patients this frequently. How are you doing? Do you have any physical limitations? Is something slowing you down? So if, you know, a year ago, you could walk around the block, 6 months ago, you could make it halfway, and now you've just kind of quit because it's just too physically hard to do it. You get lots of exercise capacity. Now, frequently in women, you might not have chest pain, but women will far more frequently say, yeah, every time I, come up the stairs from the basement, up here in my neck, and you'll see women always kind of hold their jaw or hold their neck. It's very frequent in women to have neck or jaw pain, and even in women you can get shoulder pain, and I've had a couple of them with back pain, kind of in their shoulder blades. So you've got it's not just chest pain that can be the thing. And frequently, some of that discomfort that you have may radiate down your arms. More commonly in the left, but it can be in both. Okay, so that's kind of what I would call the symptoms of coronary artery disease. I've built up a blockage, I've got some symptoms. What do I need to do? Now, what are the symptoms of a heart attack? So the symptoms are similar, but how they come on you are frequently different. Frequently, it will be the acute onset of chest pain, meaning, hey, 2 hours ago I was great, and now most people having a heart attack aren't worried about calling it discomfort or uncomfort or not chest pain. I'm having chest pain. Substernal chest pain, it may even be here in your epigastrum, meaning, right there underneath your chest bone. People will frequently say, ulcer or my gallbladder, so you can have it there as well. Most commonly occurs at rest. I wasn't doing anything and this chest pain came upon me. Frequently, if you're having a heart attack, it can wake you up from sleep. When people say, hey, I was woken up from sleep with this discomfort, that gets my attention. Very commonly associated with nausea and vomiting, and you will sweat like you've never sweat in your life. Again, diabetics, different symptoms, will many times have non-specific symptoms. I've had diabetics come to the emergency room and think they had the flu and they were having a heart attack. So that really is on our side, we have to be a little more nosy about it and just suspect that there's something going on. So, this is what a heart attack looks like in the cath lab. So that stick right there is the catheter. This is the right coronary artery. And as you can see, the dye fills up the artery. See how nice and big like a tube it is? And you see what happens right there. Nothing. No blood flow past there. So that's what happens when that blood clot forms and blocks off the artery. So what we do is we'll put down a wire across that blockage, open it up with a balloon, and we'll put a stent in there to kind of hold it open and prop it open. And so you can see what this artery looks like now, after there was a stent put right there. So you can see this artery is the same as that artery. So we fixed that up. So the reason we don't want a heart attack is we can do a lot if you're having a heart attack. But not everybody who has a heart attack makes it to the hospital. And I'm not trying to be morbid, I want to be honest. And so we want to figure out that there's a problem long before you get to this stage. I mean, we've got treatment for it, but we prefer to treat it long before you had a heart attack. So this is similar this is now the left coronary artery, and this you see right here, it stops, and you can see just kind of a trickle of blood getting down there. And so we stented that up right in that range, and you can see what good blood flow there is now. So we have ways to help you if you're having a heart attack. But you don't want to be home sitting on your couch if you're having a heart attack, okay? So, what I'd really like to move on to now is how can we prevent? Nobody wants to end up in the cath lab with me at all. And so, how can we keep you out of the cath lab? So, if you look back, and I'm not making a comment on anybody's age, but in the first part of the 20th century, 1900 through 1940, people didn't really worry about heart disease that much. In those days, it was far more frequent if you were going to die early, you died of an infectious disease. So this was in the days before antibiotics had started. And so in those days, when there weren't really a lot of antibiotics, you either had the constitution to get over your infection or you didn't. And so, you can go, I remember being in Savannah one year, walking through, they have all these graveyards in the middle of town. You just walk around, there's a graveyard. And there's so many gravestones with people who are in their teens and 20s. And then there's gravestones for people in their 70s. And so you either had what it took to survive or you didn't. So infectious diseases were far and away the most common cause of death as you went into the late 1800s and into the 1900s. Well, as antibiotics came up and we got a polio vaccine and we got all these things, the infectious disease didn't go away, but it didn't become the common cause of death. And so in the 40s, we started to notice that people were dying of cardiovascular disease. And in that day and age, things that we take for granted today, which here we are, what is it, 60 years later, I don't know that people really kind of knew what the reasons were that people were having problems with coronary artery disease. So there is a very, very, very famous study, maybe the most famous study in all of cardiology, called the Framingham Heart Study. And this started out of Boston. And so they basically said, we're going to follow a bunch of people prospectively. So prospectively means we're going to sign you up for the study and we're going to see what happens. And so this was all occurred in this town called Framingham, Massachusetts. And it was run out of, most of the study was run out of Harvard up there in Boston. So in the original study, 5,200 people were enrolled in the study, 2,300 men, 2,800 women. You had to be between the ages of 30 and 62, and you needed to have no history of any heart or vascular problems. So they were enrolling people that said, hey, you're otherwise healthy, and we're going to follow you and figure out what happens. And they're checking everything, cholesterols, blood pressures, all these kind of things. But there wasn't any medicine put in. Hey, we're going to give you this medicine. This was an observational study to see, hey, what's the natural history of this problem? And now, I mean, this study is still ongoing now, 60, 70 years later. They have the siblings of the original people in there. They have siblings of siblings. And so it's become this large study. And so they're now starting to do genetics and look for, genes and things that are associated with the problem. So, and what they found were really 5 major risk factors. So again, we kind of take this for granted. It's kind of almost, we know it now, but then they didn't know it. And so these were kind of the 5 major risk factors for coronary artery disease. High blood pressure, high cholesterol, smoking, diabetes, and family history. So of these 5, 4 are really what we would call modifiable risk factors, right? You can do something about it. Your family history is your family history. I always say you can't outrun your genes. Whatever genes you got, you got. But that doesn't necessarily mean that you're going to have it, but you have a risk for it. But there's not something you can do to change your DNA to make your risk any different. You can do a lot of things to change these top 4, and we're going to talk about that today. So, if you look at, I apologize in advance if you're not used to looking at studies and things, but I'm going to walk you through a few graphs today to kind of help you understand. So if you look at the Framingham Heart Study, and if relative risk is 1, meaning like, hey, you just have normal risk and that equals 1. So if you are a smoker, and that was your only risk factor, your risk automatically goes up to 2. And what they wanted to look at is what's the risk of a single risk factor. So smoking, BMI meaning overweight, this is total cholesterol over 220, diabetes, and high blood pressure. So the 5 yellow boxes. And so you can see that all those boxes are about the same height. Clearly with smoking being the worst risk factor. And then what they wanted to show in the red boxes is what if you've got more than one risk factor? So if you're overweight and you smoke, your risk goes to here. If you're overweight, smoke, and have high cholesterol, it goes here. If you add diabetes, it goes to there. And if you had high blood pressure, your risk is up here to 12, where your original risk was 1. So it's not just any one of these risk factors, but if you start stacking risk factors on top of risk factors, you can see how quickly your risk for coronary disease can rise. So if you look at this put into another way, this shows you what any one single risk factor is, and if you start adding risk factors, how quickly your risk goes up. So let's talk briefly about smoking. You could spend an entire talk about smoking, but nobody walked in this room today and said, you know, I think smoking's good for me and it's good for my heart. We all know that it's probably not. But let's look at the problem we're dealing with. So every year, 443,000 deaths are attributable to smoking. Not 4,000, 500,000. 500,000 deaths attributable to smoking in any one year. Of which, so chronic obstructive pulmonary disease, that's emphysema, is about 21%. Lung cancer is about 29%. Heart disease is not far behind at 28%. And then always kind of the forgotten vascular disease is stroke, which is also a cardiovascular disease, about 4%. And then other cancers and other diagnoses, about 18%. So this is not a small problem. So I'm happy to talk to anybody as far as, you know, help getting rid of smoking. Smoking is the hardest thing to change in your life. So smoking, people don't smoke because they don't like to smoke. They smoke because they like to smoke. And there is a certain physiologic and mental side of smoking. The biggest problem with smoking is people tend to put it into their life in their normal day. So they'll smoke if they're driving in the car going somewhere. It's their coffee break at work. It's after dinner. They're sitting on the back porch. So smoking becomes part of what you kind of do every day. And so it's kind of hard to change what you do every day where smoking has already been, and that's what makes it really difficult. Of all these risk factors, this is the hardest one. It's the hardest one. So basically, a couple of things to say. If you're going to quit smoking, decide it's time. You have to decide that nobody else can decide it for you. You have to decide it's time. Ask your doctor for help. There's a lot of things we can do to help. There are pharmacologic things, medicine things that we can do to help to make you more successful. Set a date. Say, this is going to be it. This is when I'm going to do it. You know, there's a lot of data out there now about electronic cigarettes, smokeless tobacco, things like that. And are these alternatives safer than smoking? Beyond the scope of what I want to talk to you about today, but so there's data going in either direction, and it's still very controversial. So I don't want to make any strong statement, you know, hey, go buy yourself an electronic cigarette. For some people that has helped, and they've been able to get off smoking. Some people that has helped, and they've been able to get off smoking. But we're not sure yet whether the alternatives are better. So, we touched briefly on family history. You can't outrun your genes, but even if you have a family history of coronary disease, you can still do something with your other risk factors. So, just because your dad had coronary disease doesn't mean you have to have it, or at least you don't have to have it as bad as he did. All right? I guess the other question I always hear is there some role for genetic testing? You know, right now at 23andMe, you see the commercials on the television and things like that. At this point, there is no one genetic test for heart disease that kind of should make you feel good or make you feel bad. We don't have any idea. And if you have a gene for something, what are you going to do about it? Nobody knows yet, you know? So I'm certainly not saying you should go out and have a genetic. I'm not against you going to have a genetic test if you want the information. But there's no one single genetic test at this point that says, ooh, if I pass this genetic test, I'm not going to get heart disease. And ooh, if I have this genetic test, then I'm certainly going to get it. You know, we're not there at this point. So I want to spend a little bit of time. This is going to be the major portion of what I finish on today, because there's a lot of myths out there about treating your cholesterol. You know, I tell patients to, I was just talking to this with Jeff, nurse practitioner who works with me, about, you know, I can give people blood pressure medicine, they just happily go take their blood pressure medicine, and then I try and give them a statin for their cholesterol. Wait, you know? So I always in clinic will spout off some numbers about why statins are so good. And so I'm going to give you some data today to help maybe clarify why we push statin therapy so much in cardiology. So this is data. This is a bit of a busy slide, but this is basically data from the Framingham heart study looking at your LDL cholesterol. So your LDL is your bad cholesterol. That's your sticky stuff. It's wanting to stick to everything. So we want our LDL to be low, L for low. Our HDL is the good cholesterol. That's the stuff that your body's collecting up, sending it off to your liver to be eliminated. We want our HDL to be high. So this is why I don't really look at total cholesterol. So a lot of people come and say, what's your cholesterol? It was 220. What does that mean? What percentage of it's good cholesterol? What percentage of it is bad cholesterol? The total cholesterol doesn't really mean a lot. I take care of a lady who has a total cholesterol of 230, and her HDL isn't even on this thing. She's got 125 HDL. So she's got this very high level of good protective cholesterol. So even though her total cholesterol is high, most of it's good cholesterol. So the total doesn't tell you anything. You want the other parts. So if you look at this, what they noticed in Framingham is the people with the lowest LDL had the lowest risk of cardiovascular events, and the people with the highest HDL had the lowest level of cardiovascular events. So it's not just an issue of LDL, it's also an issue of HDL. Now, your HDL tends to be kind of genetically set. Some of us are set to a lower part and some are set to a higher part. Men tend to have lower HDLs than women. But we want our HDL to get as high as possible. We don't have any medicine to change your HDL. There isn't one right now. It's kind of the holy grail of cholesterol research, is finding a medicine that'll raise your HDL to give you this level of protection. There's nothing that will really do it. Diet and exercise may raise it 5 to 8 points. So that's good. If you started at 25 and you can get it up to 35, you know, that's a victory. But we don't have anything at this point that raises HDL. But we do have things that lower your LDL. And so you can see, particularly if you have a low HDL, the lower you can get the LDL, the better is your risk. So we're going to talk about a couple of famous trials. This one's called the Scandinavian Simvastatin Survival Trial. All these trials have tricky names, and these guys that sit around and think about it and give it all a fun name. This one is called the 4S. If you talk to any cardiologist and say the 4S trial, they'll know what you're talking about. But it was done with simvastatin, and this was a study where they took over 4,000 men and women, 35 to 70 years old, and they had to have had a prior heart attack, or at least angina. And their cholesterols were really fairly high, 212 to 309. And so they either got 20 milligrams of simvastatin, which used to be called Zocor. So if you took Zocor, that's what this was. And then you could raise the Zocor up to 40 if your total cholesterol was still over 200. And they compared that to people on placebo. So they all got the best medicine, except half the people got a statin, half didn't. And they followed them for 5.4 years, and they wanted to look at mortality. And as you look here, this was really kind of one of the first suggestions. The green line on top is the statin therapy, and the placebo is on the bottom. They got a sugar pill. And this is just looking at survival. As you can see, out here at 6 years, that is about a 90% survival. Again, these are people who all have known heart disease. And there was about an 85% survival in the patients who didn't take the statin. So this was our kind of first indicator that statins may improve your survival. Not just talking about having another heart attack, we're talking about survival. So it reduced your risk by about 30%. So they said, well, let's look a little farther into this. And so then they came up with the heart protection study. This was a lot bigger study, over 22,000 patients, 40 to 80 years old. And you either had to have had a heart attack, some sort of vascular disease like a stroke or blockages in your legs, diabetes or hypertension, and you had to have a cholesterol over 135 to get in it. And again, it was the Zocor medicine, simvastatin. So this is a really busy slide, and I don't want you to read every word on it. So there's a lot of groups in this study, right? People that have had a heart attack, people that have diabetes, people that have high blood pressure, people that have peripheral vascular disease. And the way this graph works over here is they set everything equal to 1. And if it was better to be on the placebo, then the square or the diamond was on this side. And if the simvastatin was better, the square or the diamond was on this side. And if you look, in every group that they studied, it was better to be on the statin. These are in people who had had a prior heart attack. Better. No prior heart attack. Better. Coronary disease. Better. Everything better. So the statin not only made you live longer, this actually showed that you had less recurrent events, less strokes, less new heart attacks. So this was very interesting. Now these are kind of what we would call secondary prevention studies, okay? So secondary prevention means, hey, I've already had an event, I've already had a heart attack, I've already had a stroke, I've already got a stent. What am I going to do to keep myself from having that again? That's called secondary prevention. We've had it once, we don't want it a second time. Primary prevention means you've never had a heart attack, you've never had a stroke. I want to keep it from having it the first time. So this was a study called the CARD study, and 2,800 patients with type 2 diabetes. And they had to have one other risk factor, smoking, high blood pressure, cholesterol problems. So LDLs less than 160, triglycerides less than 600, and this looked at a medicine called atorvastatin. This is the old Lipitor. And not at a very high dose, 10 milligrams. That's actually what we would consider a low dose these days. And they wanted to look at how long it took until you had your first event. So these are people that have never had anything, so this is primary prevention. How do we keep these people from having their first cardiovascular problem? This trial was stopped 2 years early. Why was it stopped 2 years early? Because they felt it was unethical to continue the study, because the patients who were receiving the atorvastatin were surviving or doing so much better than the people having a placebo. So there's always a committee that overwatches these studies. And if it gets to a point where the treatment arm, meaning the Lipitor arm, is doing so much better than the people that are not getting it, then they'll stop the study early. And that's what they did here. They had to stop it 2 years early. And if you look at this, so this is basically your hazard of having another event. The blue line is the placebo, and the green line is the Lipitor. And you can see, starting here, even at 1 year, the lines are starting to separate, right? It was better, even at a year, to be on the atorvastatin than it was to take the placebo or the sugar pill. And as you went along over 4.75 years, you see how those lines keep getting farther and farther apart? It was better to be on the Lipitor. You had less chance of having your first cardiovascular event if you took that. So this proved that primary prevention works. If you've got risk factors for heart disease and you take a statin, you have a significantly lower risk, 37% less, of developing your first heart attack or stroke. So the other famous study at that time was this one. This is the one we all call West of Scotland. These people had higher LDLs, 192. That's really, really high LDL. And they looked at the same thing, MIs or cardiovascular death, and similarly a 31% reduction. So even in patients with really high cholesterol, taking pravastatin, which is a much weaker statin, there was a 31% reduction in having your first heart attack. So that data we all felt was very strong. So lastly, last trial we're going to talk about is the Jupiter trial, 17,000 people, LDL 130, and this is rosuvastatin, which is the old Crestor. So now we've kind of tested our way through all the statins that are in the book, and they got 20 milligrams, and they were looking for death, MI. They had to halt this study at 2 years. Top line is the placebo, the bottom line is the Crestor. Over that period of follow-up, 44% reduction in your risk of either having an MI or dying of a cardiovascular event. So I think taken together, if you look at all these studies, and there's probably another 25 or 30 of them that we could have flashed up here today, and you would have all been sleeping on the ground because you don't want to see 30 studies. But I've kind of picked out 5 of the most famous ones that involve thousands of patients. And every single one shows that treatment with a statin lowers your risk of having a second heart attack, second stroke, first heart attack, first stroke, or dying of cardiovascular disease. And that doesn't matter if you start at really high cholesterols, or like you did with this one, this Jupiter trial actually started at very low cholesterols, like 120 on your LDL. So statins make you live longer. They keep you from having heart attacks. Now, full disclosure, here's the part I always hear about. So I'm not here selling statins to you and have a box of them over here and we'll sell them to you after the talk. So this is why we as cardiologists so much are fans of statin. There's very little else out there medicine-wise that gives you this kind of protection. But we're also realists in that not every medicine is for everybody. There are real side effects with statins. I'll be the first to admit it. So, most commonly, and the most common thing I hear people complain about is they get some muscle pain. And in most of these studies, if you looked at it, about 10% of people did. Now, because you've got a little muscle pain does not mean you have this thing. Myopathy means that you start to have a breakdown of the muscle. Rhabdomyolysis is the name of that. That's breakdown of your muscles. That is rare, 0.1%. So muscle cramping does not equal that. Thankfully, this is rare. That is fairly common. And then rhabdomyolysis, where you actually start to develop renal failure and things, very rare. There is a question of increased risk of diabetes. Does it raise your sugar a little bit? Yes, statins probably do raise your sugar just a little bit. Now, you've got to, does it give you diabetes? I think that's controversial. So I wouldn't say that we know if it gives you diabetes or not. I think a lot of the time, people that didn't know they had diabetes or were working their way towards diabetes develop their diabetes. It's very common for patients to come in and see me having a heart attack. They'll say, no, I'm not diabetic. We'll put their stent in, we'll recover them, we'll check some stuff. Turns out they are diabetic. Or 3 months later, they'll come back to the office. Hey, doc, turns out I'm diabetic now. So it's a lot of times it's diabetes in progress. But I do think, I will admit, statins can raise your blood sugars a little bit. Now, the risk of diabetes itself for coronary disease has to be weighed against the risk of the statin, right? Having diabetes is a huge risk factor to develop coronary disease. So are you better taking statin and lowering your cardiovascular risk even though your sugar might go up just a touch? That's what you need to talk to your doctor about, you know? All right, you do have to check liver enzymes in statin patients. Some patients' liver enzymes go up. You need to have it checked every 6 months to a year. Thankfully, if your enzymes go up, you can stop the statin and they'll come back down. It's not known to be fatal liver problems, but if you are an internet person and you look up statins and liver, you'll find plenty of sites that say it's going to melt your liver out. And so my answer to that is this wouldn't be a $7 billion a year industry if it was melting everybody's liver out. There was an old statin on the market called Baycol. Baycol was out in the 90s. And it wasn't a very strong statin. It just kind of lowered your cholesterol a little bit. And their selling point was, well, if you only need to lower your cholesterol a little, take Baycol. That's what they were trying to push people. Well, you don't need the strong statin, use ours. And they had 3 people on Baycol that suffered liver injury. And that thing was off the market a week later. So 3 out of all the millions of people taking it, 3 people had liver problems and they pulled it off the market. So if the statins were really kind of destroying your liver, or if you have a history of liver disease, you got to be careful taking statins. So, but you do have to watch the liver enzymes. There's always been this talk about, is there an increased cancer risk and an increased risk of violent behavior? Those things probably haven't come out. The other thing that is not on my list here, but people talk about is memory. Do statins affect your memory, or do you have some sort of fuzzy thinking from it? And I would say I've seen that. Now there's also some data that shows that statins may be beneficial in patients that have dementia. So if you've got dementia, the statin may be helpful. If you take the statin, does your memory get worse? I don't know that we know. I have patients that will swear to it. Hey, I can't think straight, stop my statin. Hey, I'm thinking fine, But that's not a scientific study. And for that patient, I'm not going to make them keep taking the statins. I'm not going to grab you by the shirt and say you're going to take this. But I have heard these things. So these are kind of some of the things that you're going to hear out there about statins. Certainly the whole issue of kind of muscle pain, muscle cramping, that's real. That's absolutely real. All right, briefly, let's just talk quickly about blood pressure. The new guidelines came out recently, and for just about everybody in the room, the guidelines now say blood pressure should be 130/80. That's about where you should be. Touch higher, touch lower, but 130/80 is now recommended. So if you look here at about 130/80, you have no risk factors. That really doesn't cause you any additional risk. But as you go up in blood pressure, so this is people that have no other risk factor except for high blood pressure, 140 to 160 start becoming low risk, 160 to 179 you become intermediate, and if you're consistently over 180, you start going into the high risk group. Now, if you also have other things, 1 to 2 other risk factors, 3, or if you've had chronic kidney disease and diabetes, see, the diabetes puts you into the high risk category already. It doesn't matter what your blood pressure is. So we do want to try very hard to keep our blood pressures down more towards the 130/80 range. All right. So, ask people what they're scared of dying of, and particularly women. Women, if you take a poll on the streets, the far and away breast cancer worries women more than anything. Yet, 1 in 10 women will get breast cancer. 1 in 3 women will get heart disease. So we really need to be serious about our concern about heart disease. And there was actually just a story that came out last week in the news that estimated that maybe 50% of people have cardiovascular disease. So somewhere between 33% and 50% of people are going to be touched by heart disease in their life. So this is, take half the room, right? So I want to stress the things that we talked about today are modifiable risk factors. You can get your blood sugar under control. You can get your blood pressure down. You can get your cholesterol down. You can quit smoking. You do those things, and you've really changed your risk profile. Like I said, I don't want you to see you in the cath lab. I don't want to never see you in the cath lab. Better to not need a stent in the first place. All right, medicine and lifestyle modifications can lower our risk. Eat right, exercise, talk to your doctor about various medicines that you're taking, because there are medicines that can lower your risk. Statins are clearly superior in lowering your risk. There are some new medicines on the market coming out. There's a new one that you inject in yourself. There's 2 companies that make it. Those drugs have actually been shown to lower your cardiovascular risk. Now, they're only used right now in patients who are already taking statin and need additional cholesterol lowering, or if they have some inborn problem with cholesterol. Their cholesterol is 500, and they're very expensive. So, but there are new medicines coming around. But as of now, statins are clearly the superior medicine in lowering your lipids and lowering your cardiovascular risk. And I think the one other thing that I didn't really touch on today is the whole issue of aspirin. So aspirin's old-fashioned medicine, been around forever. And I think it's really important to separate primary and secondary prevention. If you have heart disease or have had a stroke or have had peripheral vascular disease, it is without a doubt, no argument, that aspirin lowers your risk of future events. So if you've had any of those things, you should be on aspirin of some sort. The more controversial area right now is what we call primary prevention. Hey, I've never had anything. Should I be taking an aspirin? And that has actually become a little bit more controversial. There was a couple papers that came out either late December or early in January that said maybe we shouldn't be giving aspirin for primary prevention. And so you're going to hear some things on the news about should we question aspirin. In primary prevention, meaning you've not had anything, aspirin probably does lower your cardiovascular risk a little bit, but at the cost of increasing your risk of bleeding. And so the argument in those papers was that the risk of bleeding outweighs the good side of aspirin. I think it's still very controversial that we should just be stopping everybody's aspirin who is taking it for primary prevention. I do think that if you come in and see me and you said, I don't have any problems, I don't have any family history, I'm not diabetic, I don't want to take aspirin, I probably at this point would say okay, because I think there's some data for that. If you have diabetes, in my opinion, that automatically puts you into secondary prevention. If you've got diabetes, you've got some vascular disease, unfortunately. So I think diabetics, even though they may have not had a heart attack, not had a stroke, diabetics are better served being on aspirin. So I think I'll close with that, and I'll be happy to take any questions. Sir?
Yes, would you please touch on irregular heartbeat and talk about that? And
Sure.
if you're sitting there once in a while, you feel like you're missing a heart.
Yes.
Skips. Also, on the lighter side, would you touch on if somebody scares you, say, oh, you almost gave me a heart attack.
Right. Okay. So let's go irregular heartbeat first. So irregular heartbeats are not all created equal. So when you feel your heartbeat, so normally you don't feel your heartbeat. Your heart just kind of beats along and you don't really even notice it. It kind of goes into the background. But if you should have a skip, then all of a sudden you feel your heartbeat. And so there are numerous things that can cause that. Simple things like a premature beat. You may have a premature beat, it comes, it kind of like a butterfly in there, and then it goes away. And then you get another one later down the line. Certainly if you have and so when you have an irregular heartbeat or feel your skips, that's called palpitations. People will complain of palpitations, I feel something in there. And then you can have a real rhythm problem. There are numerous rhythm problems that can cause that. And then the one that really gets us nervous is one called atrial fibrillation. Atrial fibrillation gives you an irregular heartbeat. It's irregular all the time. So normally where your heart beats like music, you can tap your foot to it, atrial fibrillation will give you a completely irregular beat. Like that. The important part of atrial fibrillation is it has a distinct increased risk of stroke associated with it. So what I would say is most irregular heartbeats are quite benign. You feel them, but they don't cause you any trouble. If you're having frequent irregular heartbeats, what you probably do is need to see somebody and just have a monitor put on, for a day, a week, and let us record your heartbeat so that we can either tell you, hey, this is just premature beats, which are completely benign. They don't mean anything other than you feel them. Or do I actually have atrial fibrillation over here and I need to be worried about a stroke? The reason that I suggest a monitor is because while patients give a great history, you really need to kind of see it on an EKG. And there are irregular heartbeats that feel exactly like atrial fibrillation, but they're not atrial fibrillation. And then with atrial fibrillation, you have to start talking about being on blood thinners. So it's a big jump if you have atrial fibrillation. So identifying, you don't want to start blood thinners if you don't need them, but you want to start them if you really do need them. So you really need to have an EKG of that rhythm to be able to say what that is. Now, as far as being scared straight, so probably not what would happen. Certainly there are weird things where people jumped into funny rhythms because of that, but I think it's what I would call rare. Now there is a thing called